Well, hi, Dr. Michael Caldwell here. I'm the Associate Vice President for Vaccine Research and Education and the Course Director for Social Foundations of Medicine. So great to have you join us today. We're joined once again by Dr. Celia Goodson, the Director of the Office of Quality Improvement at the Tennessee Department of Health. We're really so happy to have her as well. We're also going to be hearing today from Dr. Christopher Wilson, the Medical Director of the Healthcare Associated Infections and Antimicrobial Resistance Program. But right now, Dr. Celia Goodson is going to lead us off for the patient safety principles. Dr. Goodson, thank you so much for joining us. We really appreciate all the extra time you're giving us today.
I'm excited to be here, and this is the second presentation. Did Patient Safety 1 about a week ago, so following up with Patient Safety 2 lecture today. Wanted to just remind everyone that we're going back to the same principles that we talked about in Patient Safety 1. So recalling about the Institute of Medicine, National Academy of Medicine, and
that was on their quiz. That was a quiz question.
I saw that.
Yeah,
I saw that.
Was, yeah.
So recalling that safety is one of the 6 pillars of quality healthcare that they've named. Defining different categories of medical errors that are faced, understanding the impact of those medical errors, considering the impact of error prevention. What can we do to make a difference? And then applying evidence-based strategies to mitigate those errors. So once again, reminding you the 6 pillars of quality healthcare. Quality healthcare is safe, timely, efficient, effective, equitable, patient-centered, and we are focusing in this section of the course on safety. This year's World Patient Safety Day, which was September 17th, was focused on medication without harm. And I thought that was important. Since we're doing patient safety, we're going to talk about medication errors. I thought it was important for us to see that this really is a worldwide movement. So just a short video from the director of the World Health Organization.
Dear colleagues and friends, the focus of this year's World Patient Safety Day is medication without harm. Medicines are powerful tools for protecting health, but medicines that are wrongly prescribed, taken incorrectly, or are of poor quality can cause serious harm. Nobody should be harmed while seeking care. But globally, 1 in 20 patients suffers avoidable medication harm, and unsafe medication practices and medication errors account for half of all available harm in medical care. WHO is working to reduce medication-related harm and prevent this needless suffering by developing guidance and supporting countries to put patients at the center of the medication process. By informing and empowering patients, by improving the naming, labeling, and packaging of medicines, by supporting health and care workers to avoid errors, and by improving medication systems and practices to reduce the risks of harm. This World Patient Safety Day, cities around the world will light up monuments in orange at the statement that everyone has a role to play in medication safety and achieving medication without harm. I thank you.
In considering medication errors, we often in medical training think about medication errors in a hospital, but I think we really need to consider the outpatient world, which is where most of our patients are going to have the majority of their care. And it is worth noting first, let's talk adverse drug events. We talk adverse events in Patient Safety 1, meaning if something is referred to as an adverse event, we know that patient harm occurred. So an adverse drug event is a situation in which patient harm occurred. It may have been a side effect of a medication, or it may have been a medical error. Now, annually, it's estimated that about 4.5 million outpatient visits occur because of adverse drug events or are associated with adverse drug events. The adverse drug event rate is obviously going to increase the more medicines a patient's taking. One study showed that in 2016, patients from ages 40 to 79, of those patients, 66% were on at least one medicine. 22% were on 5 or more medicines. So once again, the more medicines a patient's taking, the more chance for error to occur. Medication errors can occur at different stages in the process. So they could occur during ordering, they could occur during transcribing the order, they could occur during dispensing the medication, or they could occur during administering the medication. You'll notice that every one of those I put communication next to, because that is one thing you'll see that runs as a thread of commonality through all of these errors, is the importance of communication. Looking at the bar graph, you'll see that the majority of patient medication errors occur during the ordering stage. And next comes the administration stage, when the medication is being given or is being taken. Now, a reminder to something we talked about during the last lecture, when we were speaking about the patient safety movement, and one of the things that pushed it forward was in 1994 when Betsy Lehman, who was a healthcare reporter for the Boston Globe, ended up receiving an overdose of chemotherapy. She was on an experimental protocol for recurrent breast cancer, and she was to receive high-dose cyclophosphamide, higher than usual dosing, and that was to be followed with bone marrow transplant. The provider wrote for her to receive cyclophosphamide 4 grams per square meter of body surface area, IV over 4 days. The way that was intended was that that entire dose would be spread out over 4 days. It would be administered over the course of 4 days. It was interpreted by the nursing staff and therefore administered as 4 grams per square meter every day. So effectively, she received 4 times the dose that was intended. And within a month, she had died. Another example that I want to give, and I think this is something that really meant a lot to me. I'm not able to link to the images, so I would encourage you when you're looking at this and you're pulling up the presentation on Blackboard to click and connect to these links, because I think the story is very powerful. I had the opportunity to be in a year-long program in which the cohort we were with had groups that we worked with for a year. And it was a multidisciplinary group. One of the people in our group was actually a patient advocate. She had no clinical experience at all. Her name was Melissa Sheldrick. She was an advocate for medication safety. And the reason she was an advocate for medication safety is she had lost her son, Andrew. And I would encourage you to click on that link because it's kind of powerful to be able to look at the images of this little boy that she'd lost. But I do want to take a moment to read to you what she has posted on her site. My son Andrew was taken from us because someone made a grave error one day in March 2016. That person took the wrong bottle from the shelf of the pharmacy and mixed Andrew's prescriptions. Andrew was a typical little boy who loved building and destroying towers. He could identify an approaching train by its sound, and he was always on the go. Andrew had a sleep disorder called parasomnia. The term parasomnia refers to all the abnormal things that can happen to people while they sleep. In Andrew's case, he went into his REM sleep twice as fast as normal, which caused him to wake in the night screaming and crying and then not remember anything in the morning. The doctor prescribed tryptophan, and we were told that tryptophan is an amino acid, so it's not a drug at all, and that it was found in food and that we eat it every day. But also there were no known dangerous side effects. She prescribed him a dose that required him to take the equivalent of 5 tablets a night, and the results were virtually immediate. Andrew's night waking stopped and his behavior improved. For a year, we administered his tablets in a variety of ways, as Andrew was too small to swallow the large tablets. The following year, at age 7, we repeated the sleep study, and it showed the same results. The doctor suggested we find a compound pharmacy nearby and tell them that we needed this prescription in liquid form. We took them the prescription, and they were able to make it in liquid form. We refilled Andrew's prescriptions for 18 months. On Friday, March 11th, 2016, I called for a refill for Saturday pickup, which we did, and promptly brought it home to the refrigerator, where it stayed until approximately 9:30 p.m. I gave him the dose, kissed him goodnight, and tucked him in. He did not wake up on Sunday morning. For 4 months, we didn't know why Andrew died. And then we received a call from the homicide division of the police department to come in, give a statement, and then to meet with the coroner. It was then that we learned that the bottle of medication that the police seized from our refrigerator on Sunday, March 13th, contained no tryptophan at all, but contained baclofen, mixed to the same concentration as Andrew's prescription, 3 times the lethal dose for an adult. The coroner suspected that an error was made at the dispensing level, but couldn't be sure at that time. Further investigations were conducted, and the Institute for Safe Medication Practice, and it was concluded that this was an error made at the pharmacy level. Then I discovered that if the pharmacist didn't tell anybody about their mistake and what had happened to Andrew, to our family, no one would know. I discovered there was no accountability on the pharmacy and pharmacist to make changes so that this could not or would not happen again. I couldn't live with even the idea that nothing would change and another pharmacy could make a mistake that could cost a life or cause harm, and no one would know about it. I began a petition on change.org requesting that our Minister of Health, this was in Canada, Dr. Eric Hoskins, mandate that all pharmacies report their errors to a third party for collection of aggregate data and analysis. I also started to advocate on social media, began a Facebook page called Andrew's Allies, began both the page and petition in September of 2016, and with the help of local politicians, instructed the Ontario College of Pharmacists to create a medication incident reporting program whereby all pharmacies in Ontario will be mandated to anonymously record all incidents, including near misses, to a third party for data collection and analysis. The Ontario College of Pharmacists contacted me in January 2017 and invited me to be a part of the task force to brainstorm ideas, needs, and considerations for this program. But I was also included to put a face and a concrete reason as to why this program is a necessity. Since that time, I've become a well-known voice in the pharmacy community. Hundreds of pharmacy professionals have heard me speak of my passion for patient safety. I have vowed that no other family should ever feel the pain and despair that our family has. So this to me was incredibly powerful because Melissa lost her son and made the decision when that happened that she was going to make a difference. One of the things that you will learn in the quality and safety is you'll learn about the movement toward patients and families as advocates and involving patients and families in safety improvements and quality improvements. It is very easy in the medical community to just look inward and think, we can fix this. But it is a big mistake to not include the people who it's affecting to help you figure out how to fix it and to deal with their needs. Melissa lost her son in March of 2016. Here we are 6 years later. She was actually on the steering committee for this year's World Health Organization World Patient Safety Day because it was on medication. So in 6 years' time, she has made a big enough impact to already have worked up and reached the level where she can make a worldwide impact. That to say, every one of the errors that we talk about has a face behind it, has a family behind it. And we need to think about including those people and helping us figure out how to improve systems to make things better. Now, if we think about medication errors, say as an outpatient, in an outpatient setting, I don't even know, to be honest, if y'all will end up writing prescriptions. In the world of prescription writing, before e-prescribing, there are a number of issues that can occur with writing prescriptions. Legibility is probably the biggest one. So you might write a prescription, you write the wrong medication, you write the wrong dose, it's not legible, you didn't pay attention to allergies, you haven't thought about could there be drug-drug interactions, drug-food interactions, drug-herb interactions. This image is an example of the problem that can be faced when you have legibility issues. This particular prescription, it is really difficult, if you look at the first medication, to tell what the medicine is they're writing for. Did they write for Plendil? Did they write for Iserdil? Did they write for Zestril? Of note, all three of those are from different drug classes. So it is a big deal if they're confused. The intention from this provider was that the patient would receive Iserdil, 20 milligrams, every 6 hours. What was dispensed was Plendil, 20 milligrams every 6 hours. And at that dose, in a short-acting, there is an extended release Plendil, but in the short-acting, the highest dose that is recommended is 10 milligrams. And within 7 days of taking this medication, the patient's blood pressure had dropped enough that they ended up dying from heart failure. Now, we can say, okay, electronic prescribing. We're moving from these illegible scripts and we're going to do everything electronically, which is going to help some things. But you have to consider that in the e-prescribing process, from when an order is entered into the system to when that patient picks the medications up, there can be anywhere from 50 to 100 steps that occur in there. So you can have issues, like we'll talk about later with device errors. You can have issues with the medication being sent, with the wrong thing being selected when the order entry is being placed. There can be any number of issues that occur. So we can't fall back on that and just feel comfortable knowing that that's the solution to everything. We have to be especially careful in everything we do, whether we're handwriting it or whether we're entering it into a computer system. Now, for prevention of medication errors, you'll hear the 5 rights of medication administration discussed, and those are the right patient, the right drug, the right dose, the right route, the right time. So if we think of, in order to achieve that, what are the things that we can do to help prevent medication errors? Well, if a patient is being administered a high-risk medication, there can be double checks where more than one staff member, they're going to administer this, they have someone else check it with them to make sure that they're administering the correct medication to the correct patient at the correct dose. What is standard, I think, these days in many hospitals are automated dispensing cabinets. But even those, it's the same issues that you have with computer systems. Someone has to put the medication into those cabinets from the pharmacy, so there's a potential for error there. In the same way that electronic health records often give alerts and people get a little too used to ignoring those alerts, the same thing can happen with these automated dispensing cabinets. That if they're not working well, or if they give a few too many alerts, that staff members may get somewhat complacent and just ignore those. A big thing that has helped a lot has been the development of using barcodes. Also a great system if they're used, if you have the availability at the site where the patient is, if the patient is wearing their wristband, as they should have been when they were admitted. I got to tell you, one of the people I work with was seen in the emergency room probably 2 weeks ago. And the emergency room she went to treated her and never got around to putting a wristband on her. So issues are still happening, so the barcodes would have done no good. One of the things in medication safety in the intensive care unit is when rounds are being made, a lot of hospitals have pharmacists, have clinical pharmacists who make rounds. They found that that makes a big difference in decreasing medication errors in that particular setting. For distractions, when medication is being removed from the dispensing cabinet, the nursing staff is entering the medication and they're removing it, or when they're preparing the medication, they're drawing it up or diluting it, or when they're administering it, there are many facilities that have a no interruption policy or no interruption zone. There are some places who physically have a circle of tape on the floor, and if a staff member is standing within that circle, everyone else knows they are not to be interrupted, because that is often the cause of the medication error, is when someone is distracted. There are abbreviation lists that should or should not be used, standard abbreviations. There are standardized order sets now that can make a difference with medication orders. Just the way medications are written from the pharmacy or within a computer system, they can be written in a way to take two very similar appearing medication names, but to draw your visual attention to the difference between those. Medication reconciliation is something that's extremely important at every care transition, and that is verifying what the patient is on, verifying that what is in your record, whether it's in the hospital or whether it's in a clinic, is actually what the patient is taking, and that the patient understands what they're taking and they're taking it correctly. And if you can, giving the patient a physical printout of the medications they should be taking. And then medication device improvements can help to decrease medication error, and we'll touch on that in just a little while. One thing that's important in terms of decreasing error is identifying the patient correctly. And the Joint Commission really requires that you use at least 2 identifiers. And you're going to see in almost any facility you're in, you're going to see posters that say, did you check 2, take 2? Did you check? Ask the patient's name, ask for their date of birth, or ask for one of the things that are listed here to verify that you have the correct patient. I can't speak much to this. I actually put this on here, the medical identity theft, from slides from the person who did this course last year, just because I found it interesting. We think of identity theft, but apparently something that occurs now that we have to watch for is people having their medical identity stolen in order to be able to obtain medications, to utilize their insurance, etc. Now, device-related errors, I think this is an important topic that we don't really think about too much. We can think about a device error and think, oh, well, that must mean that the people who made it didn't do a good job. that they made poorly designed, or it's just made out of equipment, made out of supplies that aren't very good, or it could be a software error. So I want you to think back to the Therac 25 that we discussed, the incidents with the software from last week's or from the last presentation. That type of error obviously can be a fatal error, can be tragic. It could be a user error that you're given equipment, you don't put it together correctly. Did you read the instruction manual? Did you follow the instructions? So something as simple as that. Sometimes we become a little too reliant on the technology we're given. One thing I would stress is don't forget the patient. Don't get so focused on that ventilator and the ventilator settings or on anything you're doing with the device that you don't pay attention to what's going on with the patient, because that's where you're going to see what's really happening. So there is an area of science and medicine. It's really in any manufacturing area, human factors engineering, but it's really, they've moved a lot of it into healthcare, trying to figure out how do we design our systems or our devices or our software or the tools we're using so that it's going to fit with our human capabilities, but also our human limitations. To think ahead, to consider the needs of the end user, but also to think ahead, what could happen, what could go wrong if the user and this system are interacting incorrectly. So the particular item that you're looking at here on the screen is a universal connector. As you see, you could connect things of all sizes, which seems like that would be really great. I mean, I could use it if I just want to connect small oxygen tubing. I could use it if I want to connect a big tube, like a chest tube, or if I want to hook it up to suction. I mean, that seems like that would be a great thing to have, and they've been used for years. But the problem with a universal connector is the very same thing that seems like a good thing, which is you can connect anything to anything. And there are great risks with that. So on this slide, these are just images that I took from the FDA's site as warnings of medical errors that could occur if things are connected incorrectly. And so this makes the point that when I say, well, you could connect a blood pressure cuff to an IV tubing with that connector, you would think, well, yeah, you could, but that's never going to happen. Unfortunately, every one of these, and this was just 4 that I pulled off, there were plenty of others, every one of these has a story behind it where someone picked up a tube and connected it to something it wasn't supposed to be connected to, where IV tubing was connected to a trach cuff. Just the little thing where you would blow up a balloon to hold a trach in place. But mistakenly, they hooked an IV tubing to it. So fluid poured into that balloon, it burst, and it filled the patient up with lungs up with fluid, and the patient died. Oxygen tubing connected to an IV, and the patient ended up receiving an air embolus and died. A blood pressure cuff tubing connected to an IV, and the same thing happened, an air embolus, and the patient died. Epidural, unfortunately, has happened a number of times where patients in labor and delivery, a bag of medication intended for epidural anesthesia was in the room along with the patient's IV, a bag of their IV fluid or medication. And inadvertently, the epidural medication bag was picked up and hooked to the IV. And there have been more, I'd say, since the early 90s, and it may even be since the early 2000s, there have been more than a dozen patients who have lost their lives because of that. Well, that's where human factors engineering comes in. Isn't there something we could do about this? Just besides saying to people, you've got to pay attention there. Yes, they can do redesign of the connectors. So it's very much like the way car keys are done. You know, this car key is not going to work on that car. This car is not going to let you lock your keys in the car. If the connectors are different for every route, then there's not a way that I can connect the IV to the epidural. There's not a way I can connect the epidural to the IV. I will say that when they first started reporting errors like this with the epidural and IV, I thinking, okay, 20 years, that must be fixed by now. But in looking at the most recent information about it, unfortunately, that's still going on. So they have made progress. They've come up with new designs, but it hasn't gone to where it needs to be. So it's not accepted, and everyone's using these. So if we think about surgical errors, you don't want the wrong site operated on. You don't want the wrong procedure done. You don't want the wrong patient having a surgery. You don't want objects retained in the patient. One of the patients we discussed last time was Willie King, who was a 50-year-old diabetic in Tampa who went in for a leg amputation, and they amputated the wrong leg. And he was the patient that was the push behind or the prompting for the Joint Commission to develop their universal protocol to try to prevent wrong site, wrong procedure, wrong patient surgeries. So there are, within that protocol, there is a pre-procedure verification process. There's the need to mark the procedure site, to perform a timeout before the procedure to verify that everything that is being done or planned is what is supposed to be done or planned. You'll hear a lot about checklists in surgery, and I think that in the next lecture that we do, we'll talk some about that and other methods that have been taken from other industries that have made a difference in patient safety. So one thing that I want to make a point about, we mentioned earlier about transition of care. Transition of care is any time the patient is moving from one caregiver to the next. It could be they're going from their primary care clinic to a walk-in clinic. They're going from the walk-in clinic to the ER. They said, you got to go to the ER now. And the ER says, oh, well, let's admit you. You're going to the floor. Oh, well, we need to send you to the operating room. Well, now we're going to send you to the post-op folks. Oh, you need to go to the ICU. Oh, we're going to send you back to the floor. Well, now we're going to discharge you back to your regular provider. Well, we want to refer you to a specialist. Any of the times you change from one set of caregivers to another set of caregivers, there is a big risk for loss of information or for misunderstanding of information. And one of the big things that we find is patients will not have a medication list that is consistent through all of their transitions of care. So if I don't tell from the ER to the ICU, if I don't tell the ICU staff everything that's important about that patient being transferred, there can be issues with medication. There can be issues with them not knowing everything that happened to the patient. There can be issues with my swaying them by telling them, I think the diagnosis is this, and then they don't pay attention to other possibilities. So there are a lot of things can happen in transition of care. Another thing that I really want to push home is documentation. Documentation errors occur incredibly frequently. And I'm going to say this from the standpoint of someone who has been in a lot of different areas in healthcare and had the opportunity to see medical records in a lot of different settings and from different providers. When you are trained to document information in a patient's chart, please always remember why you're documenting. You're putting down important data. You're putting down your impressions. You're writing your plans. You're explaining why you are doing what you're doing. If the next provider who picks that note up cannot understand all of that information, if you're not thorough enough for that to be clear, that's poor communication, and it's poor patient care, and you risk poor patient outcomes. I will tell you, there will be times you will pick up a note to read from a provider. Maybe somebody is transferred from a hospital to another hospital. Maybe they're transferred from the hospital, they're discharged, and they show up in your clinic, and you'll be reading the note from another provider. It may say, continued current medications. Well, but there's nowhere in that note that says what medications they're on. Now they think, well, I'm looking at my chart. I know what medications are on. I can look at their med list. But you're the next person taking care of them, and you don't know. So the fact that they didn't take the time to explain the medications they're on or why they changed a particular medication is incredibly important in their care. So always remember when you're documenting, why you're documenting, because that is what's going to make the difference in whether you make medication errors or not. When you get into electronic health records, there is a tendency, you're going to be tired. You're going to say, I've been working this many hours. I just want to get this shift over. It is so easy to do things like copying and pasting. Their last note, I'll just copy and paste it over to this note. Sometimes that actually can be useful because the information that you have may be some history that you do want to put down. But once again, I've seen too many documentation situations where the same exact information was moved from one chart to the next. And I couldn't tell from one visit to the next that there was anything different between the two visits. Or we might have pre-populated notes. And then you read notes and every single one of them says exactly the same thing. And I have no ability to look at that note and be able to visualize a patient at all and have any idea how this patient is any different than the patient that I just read the previous note on. So it is tempting to fall for the shortcuts. But once again, remember why we're documenting. It's the patients that we're trying to take care of. So I'm going to turn over now for healthcare-associated infections to Christopher Wilson, who is that is his expertise, and he is going to be able to tell you a lot more about that than I will.
Dr. Wilson, really excited to have you also here to participate. And he's coming right up. I thank our great students for also being here with us and participating. So Dr. Wilson is the medical director for the Healthcare Associated Infections and Antimicrobial Resistance Program. He's also part of the Tennessee Department of Health in the Communicable and Environmental Disease and Emergency Preparedness section, and he'll be here in just 1 minute. It's so great to have Dr. Christopher Wilson here again, a guest here from the Tennessee Department of Health. He is an MD, MPH. He's the medical director of the Healthcare Associated Infections and Antimicrobial Resistance Program. That's part of the Communicable and Environmental Diseases and Emergency Preparedness, part of the Tennessee Department of Health. Dr. Wilson comes all the way from Nashville, Tennessee, but originally from somewhere else. And I know we always love hearing about your stories, Dr. Wilson. Really, you got great stories.
I do have quite a few from Melbourne, Australia. So
Yeah.
a little further away than the 2 miles I took to get here today.
Well, welcome. We appreciate you being here again. We just very grateful for all your time. So let's learn about healthcare associated. I have to say, after Dr. Goodson's presentation, now yours, I'm kind of thinking I don't want to go anywhere near the hospital. I mean, right? I mean, it's like that bad things happen. Like, so why should I go?
There are
But-
particular hospitals I wouldn't go to myself
I mean,
after seeing all the data.
So yeah,
So
and that's in this country.
in this country,
Not,
this
not
state,
your, that's not why you left Australia, was it? No.
I can guarantee it's just as bad in Australia as well.
Oh no. Well, okay. I mean, and a lot of this then is really in your hands as the students and doc to really make a difference, because you might see something, you might be able to say something, right? It's not just about terrorism.
Exactly, and that's what I want to get out. You've kind of ruined my punchline at the
Oh,
end of the
no.
whole slide, which is that it's a whole team effort.
All right.
So
Well, no, go ahead now.
With-
Thank you.
with healthcare-associated infections, I could talk about this until the cows came home in both countries. My team at the health department is a team of 50, or a little over 50 now, who deal with healthcare-associated infections. 15 or so epidemiologists, 15 nurses, some pharmacists, some additional nurse consultants. So overall, there's a massive state effort working on this, and then there's a massive effort in each hospital that works on this as well. So right here we have the Tennessee State Disease Reportable List, and these are just the healthcare specific ones. This will obviously be on your exam, so make sure you recall each and every one of these as they go. I more want to show that these are just a snapshot of the conditions that at a hospital level, you'll be reporting to public health as you go along. These change every single year. So on January 1st, it'll be entirely different to the previous year. Usually not entirely different, but there'll be at least sort of 5% different from the previous year based on new outbreaks or new strains, new germs, or some advances in the field that means we've solved some problem.
So I just note there, what I don't see on here is like flu or those things, because
Yeah.
are they there? Or-
Wonderful. No, so at the bottom there, to have a click on for when you get the slides, is the whole reportable list. These are just the healthcare specific ones, or the ones that fall in our domain in healthcare associated infections. So there's a bunch of other ones, so not things that aren't on here, HIV, some hepatitis, so those that are more in the STI field, as well as some of the vaccine preventable diseases, as you've said, some measles, some other stuff like that as well, some flus on there.
Right, because I guess hepatitis B could be a healthcare associated infection,
That's
right? So
That's wonderful, and I don't get to touch on that today, but one of the fields of what my team does is drug diversion, where healthcare workers are diverting usually controlled substances from patients. There was a really notable outbreak of hepatitis related to a nurse, I believe his name was Kowalski, who ended up infecting hundreds of people and ended up testing thousands of people to see if they acquired hepatitis. So that's a true healthcare-associated infection that was introduced by the healthcare system itself and the healthcare worker. So a lot of this stuff is inadvertent, but that one was more of an inadvertent situation. So don't recall that list, don't remember it. Wanted to show you a few slides. This is hot off the press, pre-published, just for the people listening at home, of our current situation in the state of Tennessee. Don't need to worry about any of the particular information. I'm just showing you what's available on an aggregate level. So this is data from all 103 hospitals, acute care hospitals in Tennessee. This particular one showing central unassociated bloodstream infections. Here we're showing the red line is what the modelling says we should have. The green line is what the federal government wants us as a state to aim for. The blue line in the middle is where we've been over the last 5, 6, 7 years. And then we've got obviously the 95% confidence intervals there. As you can see, we're below our modelling for these CLABSI infections. Here is some catheter-associated UTI infections. As you can see, same thing. We're below our predicted. That's based on modelling. If you're really interested, I'm very dedicated to the modeling behind this, so please come and have a chat to me about it. Then there are some that we're doing really well in as well. So here is our C. diff rates across the state. You can probably tell when we started to really consider C. diff, 2015, 16, 17. We've seen sustained decline across that as we've gone on over those years. But then there are some other ones.
That's not because there's a vaccine or anything.
No, that is strictly due to core elements of infection prevention and control, and as well as, particularly for C. diff, that's an infection that's resistant to the alcohol-based hand rub. So this is a lot of clinicians being more aware of transmitting that to patients as they go along. We've got a couple of research projects set up in the state that really look into the characteristics of C. diff, which have been relatively consistent in the C. diff itself, but I think it's been the primary procedures that have led to this decline.
You have to make me think that, are you doing something special here in Tennessee, or is something like this happening all across the country, or have you done something that everyone's saying, wow, I want to, those Dr. Wilson's doing great things. We're going to implement that across the country.
If you're going to give me a pay raise, I'll say it's that last one. But C. diff rates across the country are looking very similar to this.
Okay, got it.
I do have an example of where we're not doing so well, which is our MRSA as a state. We can see here the 2020 at the first quarter has had a little bit of a dive, which means that that's the start of the pandemic, starting to get more information about personal protective equipment, basic procedures. Then we've seen an increase back to the level we were at previously, and probably an aggregate climb through 2021. I'll bring this up a little bit later as well. So showing some other things that are there. Here are some surgical site infections, colorectal surgery, abdominal hysterectomy surgery, jumping around a little bit. And so now we're getting into the actual meat. This is just, I like statistics, I like data. I'm just showing you some of the data that's available. So now we're getting into what are the most common HAIs. And as you know, it's a presentation by me, so I'll throw in some jokes somewhere. But this is the trick question. It's a trick question because the most common HAI is probably the one that we don't know about, and the one we're not following is probably the answer. So there are a lot of UTIs, a lot of bed sores, a lot of medication misses. There's a lot of events that are healthcare associated that we don't track. So a different question is which HAIs are currently reportable? And in Tennessee, that's the 3 surgical site infections there, as well as CLABSIs, CORDIs, and ventilator-associated pneumonia. Also reportable MRSA and CDI, which is why I had those graphs before, where I don't have graphs on some other particular germs that I'd love to have graphs on. Not being reportable means I don't have the data to be able to tell you how it's going. Now, for those who were really observant, on that previous list, what was missing? Yeah, I didn't think anyone would know. So what was missing was our dialysis events, which are reportable, as well as our healthcare worker influenza data as well. So when we consider healthcare-associated infections, we also consider antimicrobial resistance. That's the preferred term at the moment. Our most recent threat report from the CDC from 2019 is showing that we've got nearly 3 million infections per year of these drug-resistant organisms. These are broken up into threat levels of where there are 18 germs that are particularly noteworthy and 5 that are marked as an urgent threat. These nearly 3 million cases are killing probably 35,000, 40,000 people a year, depending on the numbers that you look at. As you can see, there's at the bottom there, they're showing some increases, some big increases in some things like some extended spectrum beta-lactamases, as well as some other things as well. So why would I bring it up if we're not going to be able to do anything about it? Here is showing some things that we've actually improved by paying more attention to it. So the first threat report, one of the major threat reports was in 2013. So since then, if we look at our 2019 data, so this is pre-pandemic, we have had a reduction in deaths from these antibiotic resistance, both in the hospital and overall. We've also seen some pretty significant declines in VRE, some CRAB, some CRPA, and some other things that we've got on the screen as well. I particularly want to point you to that bottom left-hand one, which is showing that across the country, there's been a 21% drop in MRSA. As you recall, I particularly pointed out that we've had a pretty sustained increase over the last maybe 2 years, as well as a consistently high level from our expected. So this is showing that there are regional variations based upon this, and this is leading some of our work that I'll get to in a little bit as well. So there's prevention working. Here's how we respond. Please don't read this. Just want you to know that there are based upon the organism's threat, we rank it in an order if it's most likely to cause significant harm or most likely to that's what I'm looking for, to promote antibiotic resistance to the least. So at the moment, there are things like some KPC CRE through the OXA23 gene that we're particularly concerned about, that we see a little bit here. And that goes all the way through to the tier 1 that we're a little less concerned about. The reason why I keep on throwing these acronyms out is because I hated it at medical school when the experts came in and threw out acronyms, literally just telling you what you're going to hear. Not that you have to remember it right now, but just so you can get used to hearing some of these words over and over again when the ID fellows and physicians are talking about them. It's not for you to go and look up every single thing about KPC, CRE, or anything like that. Just keep that in mind. So I wanted to quickly point out what are our infection prevention and control toolkits. So there's an entire field of nursing which is infection prevention, called infection preventionists, and they manage to certify about 2,000 people per year in that field. So these will be in every hospital you work in, sometimes more prominent, sometimes less. What they focus on is a bit of admin on the right, but down the bottom there's some really core outbreak response and control issues such as screening, testing, etc. Then as we go to the left, some of those infection prevention core elements, hand hygiene, personal protective equipment, and then the environment of care, both around the patient as well as the built environment as well, water and airflow. So here are our tools, a little bit more distinguished. When we think about all of our actions to prevent the spread of infection, these are sort of the core elements that we chunk them into. So hand hygiene, both alcohol-based and soap and water-based. Transmission-based precautions. That's things like where we put patients, what we make them wear, what we wear, how we transfer patients along, and then how we do some cleaning and disinfecting. There's a whole range of EPA-approved products depending on the particular pathogen you're concerned with. And oftentimes when we see outbreaks, it's because the inappropriate disinfecting solution has been used. We also need appropriate screening, which is screening of those exposed to cases, exposed to inappropriate practices, or people we just don't know about to do some screening. We've got to get the information to other facilities. That's information on what transmission-based precautions people are on, what their MDRO status is, as well as if there are tests pending, because that'll affect downstream facilities. And then we need to know how to collect that information in lab surveillance. So one of our major tools that we have for improving patient safety when we come to healthcare-associated infections is the implementation of care bundles. So our care bundles are usually 3 to 5, sometimes more, sometimes even less, evidence-based practices that we put together to really try to hit on some of our problem areas. This is another slide I don't want you to read. Here's just a meta-analysis of some care bundles that have been implemented for some sort of conditions over the last few years. I think it was 2017. So how does that go? This is an actual care bundle that we in my team are implementing at the moment at 3 acute care hospitals that are having higher than the state average MRSA levels, when we know we have higher MRSA levels than the nation. So what we're asking them to do is to conduct nearly universal nasal decolonization in their ICUs and intensive care units, critical care units, plus in some other units as well. We're asking for some CHD bathing. Don't need to worry what these things are. I'm just sort of giving you some more words for your toolkit. So some daily chlorhex bathing as in their ICUs, CCUs, as well as somewhere else. Conduct some audits, and then as well as expand their contact precautions. The reason why I'm going through it in this situation is to tell you how difficult it is to implement this sort of thing. For this to happen, you need to get the CMO on board, the head of nursing, the head of IP, then you need to get the ward leadership on board, physicians on board. We had to get the administrators on board because they needed to change their informatics system to be able to record these things. Then we had to find some people who could adequately audit if these things are successful. So I had to get some EPIs on board, which these hospitals didn't have. So implementing a care bundle sounds easy, incredibly difficult to do in practice, and requires a lot of legwork to be able to get it going. And then once you finish, it takes a lot of legwork to keep what that evidence base is showing to continue as it goes on. That's the key element that I really want to get on, that it's a full team effort. So as you saw from my last lecture and for all of my lectures, I'll have what are the one important slide to be able to take away. So here it's that HIIs, unfortunately, or fortunately for me, my paycheck and my mortgage, they're unavoidable. but the magnitude of the HAI is in our control. It's a multidisciplinary effort for prevention and response, and that we need to have data in the hospital for your facility. In public health, we care about some things that are reportable, but there's a lot of things that you can track in your hospital, Nashville General, over at Vanderbilt, that we don't need to know about in public health, but that would be fantastic for you to track on what's going on. So tracking it, then using quality improvement processes, which we're going to be talking about in a later lecture, and then really want to hit on that transparency is important. There are some really great articles out there that telling patients about a harm that happened to them increases trust in the healthcare system, rather than, as Dr. Goodson mentioned, that situation not being mentioned. Some pretty good research that it actually helps build trust rather than not. So that's transparency with patients, with each other, and as well as with the hierarchy in the hospital as well.
Wow, congratulations. You've solved a lot of problems.
It would be nice if I could get those MRSA numbers to come down now, particularly in those
Yes.
3 hospitals.
I get this would be a good time to ask our students if there might be any questions. Let's see, Aaron, I'm not sure if you can get them on the screen for us to see, or at least we'll be able to hear their questions. Oh, we see a student now. Hello, student. How are you? Thank you for joining us. We hope that you were able to hear everything okay and pick up on some of these great learning objectives.
Yeah, I had a question on the data he showed for the C. diff rates. And I was just a little bit, I guess, confused about what they were doing. Because I know C. diff comes post-antibiotic administration. So is it like, are they looking at, like less, like the C. diff rates, are they making any impact on that or not? That basically, my question is, are they doing some kind of interventional thing, or are they just observing?
Yeah, wonderful question. That some of those things that are being used for C. diff, antibiotic holidays is something that had some sort of evidence attached to it, as well as just antibiotic awareness on, is this required at this sort of time? Dr. Goodson touched on some of that. Is this the right patient, the right route, or et cetera? But also, do we need antibiotics for here? And as well as patient education, teaching them about when to complete a course, when not to use antibiotics. So those things have gone hand in hand with our CDI, and it's great knowledge that you know that antibiotic use is probably the number one predictor of CDI infection. So I appreciate the extra reading you're doing.
Welcome back.
Thank you very much.
How was your vacation?
Oh, it was
Yeah, it was
actually
great.
restful.
Was it?
Yes, it was.
All right.
So I really appreciated Dr. Wilson coming in. His level of expertise in that is, I think TDH is pretty excited, pretty fortunate to have him leading that team. So this is just a slide I wanted to bring back up from the last lecture to remind you, after all of this, we're talking errors, we're talking, harms to patients. Just to remind you that we and the staff of hospitals, clinics, etc., we are humans and we are going to make mistakes. The goal is that we want to look at our systems, our complex, imperfect systems, and we want to find ways to improve those to help decrease those errors. One of the things I noticed is that y'all were asked to go to, it's October, so it's time for haunted houses, and in the hospital, that would be the room of horrors. And I saw that y'all were asked to go to the simulation lab, to the room of horrors, and try to find various medical errors that were in there. Very much like those slides, those images from the FDA site, I was thinking after I left of a personal situation that I had once again, we want to think, well, nobody's going to just pick something up and hook it to the wrong thing. So when you go into that room and you're looking for those medical errors, remember that, yes, someone is going to just pick up a tube and hook it up. When I was a resident, and I may have even by that point been an ER attending in the same hospital, my father was admitted to the hospital for cardiac surgery. I left the emergency room and went to his room just to spend a little time with him, and noticed that the tubing for his chest tube had come unhooked and was laying on the floor. And I called the nurse to point it out to them. And the nurse picked it up off of the floor and hooked it right back up to the chest tube. And I realized in that moment that if someone who had done their residency in a particular hospital, so they knew me well, who now was an attending in their emergency room, so I was still there, if her family was going to have things like that happen to them, then any and every patient was going to have things like that happen to them or their family. Another reason I'm big on patient advocacy. So when you go into that room of horrors and you say, well, no one would actually do that, unfortunately, they will. So always be on the lookout.
So happy Halloween. I should put a plug in here. You know, we have one of the best haunted houses in the country here in Nashville. Did you know that?
I didn't know that.
It's called Nashville Nightmare. And the reason I know this, too, is because when I was the Nashville Public Health Director, I had to, and it was still COVID, I had to do a COVID inspection of the haunted house to make sure it was COVID safe to have your haunting. So I needed to make a special designation to designate the Nashville Nightmare as a museum. I said it is a museum because we didn't have all our legal mumbo jumbo about what we were allowed to do, haunted houses. So I waved my public health official wand, and yes. Well, no, it's still here.
But it would have been covered. Everyone would have had masks,
Oh,
and
well,
they had to be creative.
Well, one of the things that we did, I think, still to this day is, the people would get close to you and scream, right? Like the characters. Well, what they did is they'd stand a little further back and they would just go like this, and they would press a button where they would have a speaker go, so it saved their voice. So it was an occupational medicine, advance, right? And also it reduced the COVID spread. And anything that they would have to touch, we removed that. So
and
it was
that's systems thinking.
Thank you.
Just like
That's
the
right.
slide, you got to look at the system. You got to think outside the box. How can we change what's going on?
I think we should
That was beautiful.
maybe do a site visit to see how Nashville Nightmare is still doing. It's the right time of year, so I don't know. Well, anyway, I couldn't resist. Tell you more about it in class, but thank you. All right, but please, they have about 7 or 8 different themes, so you can get a ticket for 2 or 3, and you spend a whole evening
Are any
there.
of them medical themes?
Yeah, there really are. It's so cool. It's so cool.
Yeah, y'all might be able to get a little part-time job or something there.
It's a lot of fun. Nashville Nightmare. Okay, well, we'll put it on our list. Thank you. Well, anyway, back to, being in the horrible House of Horrors hospitals. Right.
And so that, I do encourage you to, and it may just be required that you have to, I don't know, but if it's not required, I really encourage you to go to the simulation area to look at that, because simulation is one of the best training techniques and one of the best ways to learn. So I just would encourage you. I've not actually gone to see it, but I would like to very much. That's all we have for the presentation today. We have another patient safety lecture coming up that both Dr. Wilson and I are looking forward to. So I think it's going to be interesting. He's going to share some of his background in aviation and how safety in aviation applies to safety in healthcare.
Well, that's great. Well, these references really are important, and I see some of them have links, so really you could dig into some of this. I think what I'm going to do is ask Dr. Wilson to come back, and so the two of you, Dr. Goodson and Dr. Wilson, can take any remaining questions, and then we can just wrap up from there.
No, so I think we have a few students playing along at home today. Were there any questions at all from this patient safety component? So this was the second one. Who can I see? Anastasia there too?
I have
Maybe?
a question. Hi.
Hey,
Good afternoon, Dr.
nice to see you
Wilson
again.
and Dr. Nice to see you as
Hi.
well. So my question is actually for Dr. Goodson. So when we were talking about medical errors and you shared with us a story about Melissa's son and the error that was made on the pharmaceutical level, I just wanted to know, like, are there any like resources or protocols like put in place for the patient to actually use instead of having to wait for like the pharmacy or the doctor to like report their own error? Like, what sort of resources are available to the patient?
And there actually are patient reporting availability for patients to report. And the Institute of Safe Medicine Practices, which there's a link on one of the slides, patients are actually able to directly connect to that group. And that is a group that when you go to ISMP, you're going to end up on a site here within the United States. Excuse me. But there are branches of that. So Melissa is actually works with ISMP in Canada. So there are branches of that in other countries as well. But yes, there are places like that where patients could reach out directly and gain assistance in advocacy.
Thank you.
Yeah, that's interesting if I would notice an error. Yes, thank you. I feel like we're on the telephone. Let's.
Like we're doing a telethon.
So, well, I have two questions, but my first one is about like medical identity theft. So I noticed stories of like people using their family members' identity to go to the doctor, because everyone doesn't have insurance. So is there ways to measures in place to like identify these situations and not only prevent this from happening to these dangers, but like help the patients to get the resources they need?
And I'm going to say, like I said during the presentation, I put that on the slide because it was included in the slides from last year. And I thought, well, isn't that interesting? It intrigued me. I did not have time to really look into it because I had the same questions that you have. I thought, well, how would you know if you had a patient that was the case? That it raised a lot of questions. To me, when there's something like that, I would just encourage you to do the same thing that I'm going to do, which is I'm going to go doing a bit of searching on the internet, trying to figure out, or I don't know, there may be articles in PubMed, I'm not sure. But I really want to learn more about that because I did not realize that it was an issue but I would think not only as a patient do you need to be cautious about that, but as healthcare providers, we need to learn more about it. So I'm sorry I don't have an answer for you, but we both can go on the same journey trying to find out.
Well, hi, Dr. Goodson. So my question is going to be on the EHR transition portion of your lecture. So you mentioned that every time a patient gets moved, information is lost. And I actually, when I worked as a scribe, I saw that firsthand, where we had patients come in sometimes even after surgery, and we had no idea what was going on. And we were asking the patients to tell us what the other doctors had told them. And in healthcare field, we've noticed time and time again that patients may not understand fully what they're going through, and they may not understand exactly what kind of medications they're supposed to be on. So I know the EHR system set up for healthcare providers to be able to access it. But I was just wondering about the accessibility, like if it goes through, like if there is the same, is there like a same EHR system out there where doctors are obligated to upload the patient's information so that other hospitals can easily access them, or other providers and doctors can access them?
Unfortunately, no. I will say in some countries where, I'm sure Canada would be a situation like this, where there's kind of a universal healthcare system, you would have access to records wherever you're logging in from. So you'd have access to a patient's record. In the United States, you have any number of vendors for electronic health record systems. And theoretically, they should talk to each other, and you should be able to transfer information back and forth. That's one thing that when you do talk aviation, I think that is one point that I think is amazing, that if you think about technology and in that industry, how it has to talk to each other no matter what vendor made it. That's not the case with healthcare, especially here in the United States. So you will have, if you happen to work in a system, and so I'd say, let me think of a big system like Kaiser Permanente that's out on the West Coast. You may have hospitals and clinics, a number of people on the same system, and you're going to be able to see patients' information no matter where, what level you're at in that healthcare system. But I don't know of a system here that is anywhere close to connected like that. So patient portals are helpful when patients can have direct access to their records, so that, say you are home from the hospital, you go to your primary care provider, you can log into the patient portal and you could show the primary care provider your information from the hospital. But short of that, providers are not able, unless they are part of that system, unless they have privileges at the hospital and are able to log in themselves, they don't have all the information they need. They're having to do the same really old-fashioned submission of a request for medical records to the medical record department. They are now developing systems that are kind of third-party systems, if you will, so that it is, and I apologize that I can't think of the term, but it is a system that would be out here, and the patient could allow the hospital to dump their records into this system. They could then allow the doctor to dump their records, and they could allow providers to reach in there and get information from it. So that is one direction where things are going to try to improve, try to decrease errors, try to improve access to up-to-date and accurate information. So I think things are going in the right direction, but just to see how slow things have moved, I'm pessimistic about how long it's going to take.
And as we're recording this, there's a very interesting situation going on in East Tennessee about a data hack at a major hospital system out there. So please go and have a read on, I think there's an article in the Washington Post, the Tennessean's got it up at the moment as well as we're recording this. So if you're listening to this later on, go and have a look at what ended up happening with that particular breach.
Well, it's interesting you mentioned that, Dr. Wilson, because when she talked about the third party, my first concern was safety. Like, how safe will it be? And I was just thinking, like, HIPAA laws and all of that. Like, how would that work exactly?
You're absolutely right. And security is one of the data modernization effort key principles that we're looking on, which is probably an entire course on its own, data modernization and into bioinformatics. But overall, that's another very interesting field for those that want to be on the more medical technical side at some point. Thank you. This is great. I've had no questions. That must mean I've done an excellent performance. I'm very happy with that. Or I did a very small performance today compared to Dr. Goodson. So overall,
I just left them wondering. It's like, I don't,
thank you.
I didn't understand.
Okay, so I think we're done. I think it's beer o'clock.
Wait, I have one more question if that's okay. Oh, can y'all hear me? Oh, I can hear you. Can you hear me?
Yeah, I just might need you to speak up just a tiny bit more.
Oh, my question was like, as students, especially we're going in courses next semester, if we see something like, someone making an error, someone doing something uncleanly, like to get a patient sick, like what's the best way to go about reporting that? Because that can be scary, with the risk of like retaliation against you as, the little person just in the room.
Wonderful. I'm managing an outbreak at a hospital in rural Tennessee at the moment, where the reporting mechanism was the anonymous staff reporting system was the reason that the outbreak was detected, and that was a scope reprocessing breach. So most facilities will have an anonymous way to be able to do it, either through HR or through the clinical side. So that's something that I would encourage you to explore in the hospitals you go to, as well as knowing that direct confrontation isn't confrontation about the person, it's about the action. So keep in mind that no one will ever look down on you. And I remember as a second-year medical student in my first surgery, when they were about to wrap up and I said up to the surgeon, I don't remember hearing the pre-closure checklist. And he responded, we did that. And I said, I don't remember hearing that. Can we do it again? And I was looked at very strangely for saying that. But it was also something that he later came to me and said, you were wrong, but I appreciate you doing that. So overall, I think those are two options that you'd be able to utilize from where you are right at the moment.
And that is the ideal setting. So yes, unfortunately, you will end up in places where you're afraid if I say something, am I going to be given a hard time by the attending above me or by, but the goal of in the patient safety movement is that things are moving to the point that it is the expectation that if you have a question, you would say something. That you would say, oh, you might have forgotten to wash your hands there. That you would call it out. And that would be part of our training for our staff, is that we expect to hold each other accountable. And sometimes you do have to just be brave, like Dr. Wilson was, to say, they may not take this well, but I didn't hear it, and I'm going to say it, because it's the right thing to do. And I think these days, if you did end up facing any retaliation, I think you'd have a whole movement behind you that you could reach out to for support. Because I don't think it would look really good if an organization was retaliating against you, when you could say, hey, this is the way the world is moving. This is how we take care of our patients.
But thank you for those questions. That's the end of our performance today, end of the lesson today. Please come to the next lecture. Bring as many hard questions as you can. That's the aim, is as difficult a question as you can get. I want us to both go away and go, gee, I didn't know the answer to that. I'm going to do some more reading. So let's do that for the next lesson and see you all next week.
Thanks, y'all.